أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. It is a class, a tutorial for the final year MBBS, that a scenario of something about breathlessness and discussion in relation. I am Professor Sayyid Ali Haidar. I am visiting professor of medicine at the Janasian Medical University. This is the scenario because we actually have got experience that the problem-based learning, PBL that is called, is more effective type of learning if it is done properly, rather than the lectures and tutorials of long duration. Group discussions, or rather short tutorials, which is called which should have a problem to be discussed. Rather, it is more effective way of learning medicine. That is called the problem-based learning or scenario-based learning, SBL. The scenario is that a 58-year-old farmer brought to the casualty with complaining of progressive breathlessness. The last 6 months he had left smoking 2 weeks back. Means ex-smoker just 2 weeks back. On examination, temperature was 99 degrees Fahrenheit, 99.5. Low-grade fever, pulse 106 per minute. He is tachycardic, high volume pulse. Character of the pulse, blood pressure was 150 by 98. And there was central cyanosis, positive with a clubbing, also positive. He's got the barrel-shaped chest with sonorous rhonchi all over the chest, wheezing, auscultative wheezing sound, are called the rhonchi. The chest investigation, hemoglobin 15.8, about 16 gram. He has got erythrocytosis. TLC was 10,900, slightly increased. Platelet is 1,75,000, which is normal. Random blood sugar is 170 milligram, which is normal, and the XH is dark lung fused with flat domes of the diaphragms. From this scenario, you should collect the soft data and the hard data, and then you answer this question after this. This differential diagnosis. Give the relevant investigations, what is the most likely diagnosis, and justify your diagnosis, and how will you manage, or the lines of management. There are 4 parts of every scenario. In your whole life, you have to answer these questions. To track the soft data in this case, and hard data in this case. How will do this? Age 58 years, farmer, shortness of the breath, and low-grade fever, tachycardia, and the platelet 1,75,000, random blood sugar. These are all soft data of this scenario, because that will not lead to one diagnosis. Multiple diagnoses can be made. The hard data is that the person of this age group has got the progressive breathlessness for the last 6 months, so shortness of breath, chronic in nature, and he's a smoker. He left just smoking 2 weeks back, means he's still in the zone of smoking. You see, he is a smoker still. And he has got the central cyanosis, which is hard data, clumping hard data, and positive barrel-shaped chest with sonorous rhonchi all over the chest. And investigation was done. Hemoglobin is 15.8 gram, TLC is 10,900. The platelet is, these are the important one, and the excess chest are the hard data. The flat domes of diaphragm, hypertubulancy. This is the hard data. Depending upon this, the list can be made of the differential diagnosis and the diagnosis. differential diagnosis. Soft data, this is which is I have written here. And this is hard data: smoker, clubbing, cough, dyspnea, barrel-shaped chest, X-ray chest, impetus, tonsillency, flattening of the domes of the diaphragm. The differential diagnosis is COPD, or it may be obstructive nature of the lung disease, bronchiectasis, extrinsic allergic alveolitis because the farmer, pulmonary eosinophobia because he is living in the environment, pneumoconiosis is possible in this case, and pulmonary COX is always should be excluded in this type of persons. Most likely diagnosis is the chronic obstructive pulmonary disease because obstructive nature of the disease, because he is ex-smoker, progressive dyspnea, there is cough, and a barrel-shaped chest, and sonorous bronchial distributed all over the chest wall. He got central cyanosis because SO2 or PO2 is reduced, and blue blotters that is called, and X-ray evidence of the hypertonsillency are there in this case with the flat domes of the diaphragm. Evidence of the COPD classical X-ray presentation. So the patient of the chronic obstructive pulmonary disease. What is this chronic obstructive pulmonary disease? Characterized by the presence of the airflow obstruction. It is the expiration which is a problem. Caused by the emphysema. There are two polar ends of the disease. One end is emphysema, one end is bronchitis. There are two polar ends. Purely emphysema or pure bronchitis is usually not found. It is not very easily found. Rather, it is a predominant emphysema, predominant bronchitis, chronic bronchitis. In between the two, you can add the chronic asthma, you can add the bronchiectasis, you can add the bronchiolitis or bronchiolitis obliterans, etc. These are all obstructive nature of the diseases. And it is generally progressive in nature and may be accompanied by the airway hyperreactivity. May be accompanied by the airway hyperactivity. The activity, you have to take inspiration and then expire. All phenomena will be overactive. And maybe a partially reversible if you give the bronchodilation. So they are partially reversible. It is not permanently reversible disease. If it occurs, it means you will live with it. But they are partially reversible. You can manage it. That is the correct word to use. So these are the rings. One polar end is chronic bronchitis with emphysema. I put the asthma. I also will put here another ring, Olympic rings, 5 rings. One is what is called the bronchiectasis, another is here is the bronchiolitis obliterans or chronic bronchiolitis. There are 5 rings like the rings of the Olympic, COPD. Polar ends are emphysema and chronic bronchitis. In between the two polars, there will be chronic asthma, bronchiectasis. It may be bronchiolitis obliterans, that is a disease of the obstructive nature of the disease, although it is interstitial lung disease. Histiocytosis X, that is. Now, emphysema description is that we will talk first of emphysema. Definition is given here that it is the abnormal permanent dilatation or enlargement of the air spaces distal to the terminal bronchioles. Permanent enlargement. And second thing should be accompanied by histopathology. It should be accompanied by the destruction of the interalveolar septa or evidence of destruction of bronchioles oblique. 2 things should be there, these 2 things, to diagnose emphysema. These are the essentials of diagnosis. Chronic bronchitis description is the presence of the chronic productive cough for clinical definition. 3 or more months in each of the 2 successive years in a patient in whom the other causes of the chronic cough have been already excluded, like pulmonary coughs or sarcoidosis and others, already excluded by you. 3 years or more months for 2 consecutive years. It is the productive curve, always. Virulent productive curve. Causes of both are intermingling problems. Cigarette smoking is one of the leading cause of the COPD. And clinically significant obstruction develops in the 15% of the smokers. In very first decade of their smoking, 80 to 90% of COPD deaths are related to the tobacco smoking. In vaping is included hookah and other type of inhalations. And it's more than 1 in 5 deaths is a result of the cigarette smoking. If the mortality rate is directly related, in most of the cases, in the COPD is related with the smoking. At one time, Russian countries do not, agree with this. Now they agree with the thing that cigarette smoking is actually a problem. Nicotine stimulates the sympathetic nervous system, resulting in the increased heart rate and peripheral vasoconstriction and increased BP and cardiac workload. And that is all right, because nicotine effect, this is the nicotine effect. It does not cause any obstruction, only peripheral vasoconstriction is possible. But other things are important. The compound problem in a person with the coronary artery disease, there are a lot of compounds in the smoke which reduce the ciliary activity, possible loss of ciliated cells, abnormal dilatation of the distal air spaces, destruction of the air interalveolar septa, carbon monoxide is increased in the blood, increase oxygen carrying capacity, it will decrease the oxygen capacity because of the carbon monoxide. It produces the carbon monoxide. Smoke impairs the psychomotor performance and judgment. Cellular hyperplasia, reduction of the mucus, it will reduce in airway diameter. The caliber of the bronchi and bronchiole will be reduced. And third thing is increased difficulty in the clearing secretion. All the secretions are more, but you cannot clear because of the lower ciliary activity. In these cases, they are also competing with the alpha-1 antitrypsin, which is the compound which helps in the production of the mucus. It also helps in the dilatation of the alveolar septa, maintenance of the alveolar spaces. So smoking indirectly destroys the alpha-1 antitrypsin. In this way, it will cause these problems. It is possible. This is a theory, but it is possible. Secondhand smoking means the passive smoking associated with the reduced pulmonary function, increased risk of the lung cancer, increased mortality rate from the ischemic heart disease. It is dangerous. The causes infection, major contributing factor to the aggravation and the progression. If you add an infection, then definitely it is very harmful. Hereditary deficiency of the alpha-1 antitrypsin produced by the liver and found in the lungs accounts for less than 1% of the COPD cases. It is usually not. But the acquired interruption of the smoke with antitrypsin activity is proved. Emphysema results from the lysis of the lung tissue by proteolytic enzymes from the neutrophils and the macrophages. It will enhance the destruction, which is already going on. This is the pathophysiology which is described, which I already mentioned out. So, in case of the emphysema, it is entrapment, hyperinflammation of the alveoli, destruction of the alveolar walls, destruction of the alveolar capillary walls, narrowed airways, and loss of the lung elasticity. Passive activity is the expiration is gone. And that is why the air trapping phenomena. Emphysema may be two types, centrilobular, in the central part of the lobule of the lung, most common. It may be panlobular, that is destruction of the whole lobule. This condition is associated with the alpha-1 antitrypsin deficiency. It is less than 1% of cases. Rather, it is centrilobular. Panlobular is only one case. And another condition which is perihilar type of emphysema or bronchitis, which is seen in cases of vaginal gematosis, or in cases of what is another condition which is called the perihilar, emphysematous changes, both hilars around it, will be ABPA, aspergillosis, that is allergic bronchopulmonary aspergillosis. So these are the actually pathophysiology which is described here, and you can read it from the book. Very, very detailed account is given here. I am interested in the clinical manifestations. Dyspnea, shortness of breath, progresses in severity. Patient will first complain of the dyspnea on exertion and progress to the interfering with the activity of the daily lives, and rest, it will be disturbed. And in emphysema, the minimal cough will be minimal, with no to small amount of sputum production is very less. In comparison with the shortness of breath, which is more in emphysema, the overdistension of the alveolar causes the diaphragm to flatten and AP diameter to increase. That is a barrel-shaped chest. But the thing is that in this emphysema, the coughing is minimal in relation to the breathlessness. Opposite occurs with the chronic bronchitis, just opposite. Polar ends, that is why I said the polar ends. This is the barrel-shaped chest. The AP diameter is more than the transthoracic diameter. Look it, the sternum is protruded. And other one with the ribs become fixed in inspiratory position, basically. In inspiration, they go air trapping. Pursed lips, breathing down emphysema and central cyanosis, prolonged expiration, reduced sternal junction here, because you have to use the clavicular sternocleidomastoid and trapezius will be action. They are the use of accessory muscles, intercostal in drawing, and you will find the heart sounds loudest in the epigastrium than in the thorax, because of the distension of the or inflation. The masked, these sounds S1 and S2 will be masked, and there will be sonorous type of bronchi, that is called, rather in this case, or sibilant bronchi. Bees will be there all over the chest. Patient loses weight despite adequate caloric intake, losing weight day by day, because he needs to stimulate the accessory muscles and the diaphragm's overactivity. And he has to bend forwards for relaxation from the shortness of the breath. In the chronic bronchitis, the pathophysiology, actually it is the destruction of the cilia, it is the retention of the fluid, all the hyperplasia of the mucus-secreting glands, but unable to clear it properly. These are the major findings you will find in the chronic bronchitis. So, in chronic inflammation, it is definitely a pathological mechanism causing changes in these cases of hyperplasia of the mucous gland, inflammatory swelling, and excess thick mucus, which he is not able to clear it properly. So in this case, again, the greater resistance to the airflow increases the work of breathing again. Hypoxemia and hypercapnia develop more frequently in chronic bronchitis. Hypercapnia, increase in the carbon dioxide concentration in the blood with hypoxemia. More commonly seen in chronic bronchitis in comparison with the emphysema. So these are the bronchitis actually. Basically the problem is this is productive curve not cleared properly, as already said, and the hyperplasia of the glands, production of the thick mucus which cannot be cleared. More common in the history of smoking or asthma is the cough. It's often ineffective. Cough reflex is ineffective to remove the secretion, because the person cannot breathe deeply enough to cause airflow distal to the secretions. And bronchospasm frequently develops, you find the sonorous type of bronchi all over the chest. Now, initially, in chronic bronchitis, the frequent productive cough during winter and frequent respiratory infections are more common. Bronchospasm at the paroxysms of the coughing, the cough, and dyspnea and exergy and history of smoking should be always be there in most of the cases. Rather, they are of normal weight either, or they are heavy set because they are using, because of the appetite, they are using more and more carbohydrates consumption, and they have got the ruddy or bluish red appearance, that is slightly cyanosed, that they are blue blotters. In emphysema, they are pink puffers. They are pink puffers because of the polycythemia. Although polycythemia is more common in chronic bronchitis because it is rather more cyanotic condition will actually dominant in this condition. That is why blue bottles. The hyperventilation and hypoxemia and hypercapnia and retention of the carbon dioxide will cause hypoxemia and hypercapnia. This is a chart which is essential to be remembered for all of us. One is emphysema polar, one is chronic bronchitis polar end. Clinical features in emphysema is 30 to 40 years of onset. Here is a younger patient involved in chronic bronchitis. Body build is thin. In emphysema it is normal body build, and in this condition and leading up towards the obesity. The health history is generally in emphysema, occasional insidious dyspnea, smoking. History in chronic bronchitis, recurrent respiratory infections are there, and patient could have repeated chronic acute bronchitis, or rather I will say some admissions may be possible with pneumonia. Smoking is always related with this. Weight loss often marked in emphysema, absent in the polar bronchitis, is absent a slight. Dyspnea is more in emphysema than coughing. Already said. Here is coughing is more than the dyspnea. It's variable dyspnea. Sputum is scanty, mucoid, or the very, very dry type of cough. It is copious in amount, especially in the morning, and mucopurulent. Sputum, cough, negligible in this case. Considerable, which is very important hard data for the chronic bronchitis. The cough. Chest examination, the marks in AP view and quiet or diminished breath sounds and limited diaphragmatic exclusion. Slight to marked in clean epididymis, same you find. Same clinical features on examinations. Cough pulmonary is more frequent with chronic bronchitis, that is chronic pulmonary hypertension leading to the cough pulmonary, right ventricular failure. But in emphysema it is rare, except in terminal stages. In this condition it is very, very, it is terrible state. I will say the patient wants to die, but he will not die. And he will demand, and he can write on the piece of paper, please give me the poison. Some poison so I can sleep well and I will die. This is the wish in these persons. In this person, frequent with many episodes, because they are young people, they can survive these episodes until the end of their life. Again, the same thing again. They want to die, but they do not die. And they wish to die, but they do not die. So consent is given to the doctor, please give me a poison. Again the same, but in a young age. In their old age, 70 years, 40 years. And this is the wish of these patients. Most horrifying scenarios I have seen with the terminal states of emphysema and bronchitis. Now, anyway, the diagnostic study results, the ABGs near normal, mild PO2 or SpO2 reduction, and hypocapnia because of the excessive breathing, carbon dioxide is out, hyperinflation, flat diaphragm, accentuated peripheral vessels, attenuated peripheral vessels, and small and normal heart, widened intercostal margins. And here in the case of chronic bronchitis, reduced PO2 but increased PaCO2 because the retention occurs of the carbon dioxide. Again the same thing. There will be cardiac enlargement in this case, the small heart in this case. Otherwise all features are the same. Here are the rhonchi are more common, here are the clefts are more common. Now here the lung function test, the total lung capacity is increased, in normal slight increase, same one, residual volume increase, vital capacity is decreased, FEV1 is decreased, and FEV1 to ratio to FVC decreased, less than 70%, decrease is less than 70%, same one, whether it's polar emphysema or polar bronchitis. And total lung capacity in both of these conditions is more increase in emphysema rather than in chronic bronchitis. Total TLC, total lung capacity. Complication leading to secondary pulmonary hypertension, leading to the right ventricular failure, leading to the chronic right ventricular failure, cough pulmonale occurs, repeated pneumonias, and they will go to the acute respiratory failure, type 2 respiratory failure, where carbon dioxide is increased with hypoxia in chronic bronchitis, and respiratory type 1 failure occurs with emphysema, where hypoxia is there but reduced or normal carbon dioxide in the blood. Diagnosis is the X-ray, you can do the physical examination, you can do the pulmonary function test, which I have just mentioned out. ABGs, here you see the PO2 is reduced, PaCO2, especially in the chronic bronchitis, increase, otherwise normal. Emphysema, pH is respiratory acidosis occurs because of retention of carbon dioxide, more carbonic acid is formed, the respiratory acidosis, compensated by bicarbonate, increased bicarbonate level in the later stages because compensate, or either it is the compensation. And then it is actually shown here, look, the diaphragm are flat, hypertransference is there, small heart it is, aortic knuckle is there, bronchovascular markings are very, very thin coming out of the hilar. In chronic bronchitis, dirty lungs, the bronchovascular markings are numerous in amount and they are touching the lateral wall. Here you can see. The heart may be enlarged in this case, in cases of the chronic bronchitis. The flattening of the dome is the same one, intercostal spaces are increased, yes. So the collaborative care is there. Just quit the smoking. This is one of the most important things. Second thing is, remember, the drug, or rather the gold standard management is the intermittent oxygenation will benefit more than the pharmacological intervention. I will repeat it again. Intermittent oxygen consumption is, or oxygen therapy is more beneficial than pharmacological therapy. Otherwise you can give the bronchodilators in any form, LABA will be given, or the SABA, short-acting beta-2 agonist, or the long-acting beta-2 agonist by nebulizer or MDI, metered inhaler. Anticholinergic like all the ipratropium bromide, it is available here is the Atrovent solution. For the nebulization solution it is. Rather, I already said that actually the care you give, the quit smoking, breathing exercises, the physiotherapy, you should do the patient, what is called the counseling, and that is important, they have got an important role. And intermittent oxygen therapy should be given. Along with the helping tools are the bronchodilators in any form you can use if it is needed, just like in asthma. One other condition becomes, recurrent because it is a recurrent condition. And you have to do the pulse, these exercises which are written, diaphragmatic breathing, available on the Google. You can, there are lectures on it, and pulse lip breathing available on the Google. You can see on the video how they are doing it. That is half coughing, again is the exercise, half coughing. And the chest physiotherapy, in postural drainage, percussion, these are the chest physiotherapists will do this. Position of the postural drainage is this, whether cough starts in which place. The positions are here, they are seen. To encourage the patient to remain as active as possible, do not lie down for a prolonged period of time. Use 2 pillows when he wants to lie down. Lung volume reduction therapy, reduction surgery was practiced, although its limitations are there. Carotid body resections are possible. These are the surgical therapy. Another mode of the surgical therapy is also available, where the part of the lung is removed rather than the major lung is removed. And multiple surgeries can be done. In the end, you have to go for the lung transplantation because the lungs cannot be regenerated like the previous ones. It is not possible. Nutrition, if you give the more carbohydrate, more carbon dioxide will be produced, and it is the retention will give this problem. So nutrition therapy, the most proteins and the medium fats should be given. And they should take 4 or 5 or 6 times. Intermittent type of nutrition is more effective. So these are the things which are important actually for the final year is concerning. And about this is stop smoking. Patient, they are trying to smoke. Otherwise, you go for the nicotine replacement therapy, NRTs that is called. The sessions are there for nicotine therapy. Ambulatory care was available in the world, which are called the developed countries, where rehabilitation therapy at home is applied, not in our country. Nursing management definitely is very important. Nurses are there trained in this home care, and they also encourage the patient performing activities and eating and other things. These are the very important supportive measures which are written here, because you cannot help the patient. So sexual activity can be maintained if you do these things. These are write it down 1, 2, 3, 4, 5. I don't want to discuss. So nasal saline spray should be done because nasal blockage should not be done. Decongestant drops, mild type of decongestant drops can be applied if there is DNS, deviation nasal septum, and nasal steroid inhalers and long-acting thiophylline can be used. Thiophylline, xanthines are, good. They decrease bronchospasm. There are very useful xanthines. There were 5 actions of xanthines or thiophylines. Number 1, they activate the respiratory center. Number 2, they increase the effort, that is inspiration and expiration. Number 3, they will act on the heart for the pump. They will increase the contraction of the heart indirectly. Thiophylline also activate the diaphragmatic activity, and thiophylline is also a diuretic. So preload will be less. There are 5 actions of the xanthines, but because of you can't give them for a very prolonged period of time because the tolerance develops with the drug. So you have to skip the drugs for 15 days and then restart, and then this is very one of the most important therapy. That is xanthines or thiophylines. And again, this is depression and why I have done this. and there are questions certainly, about the persons who do not believe in the Almighty God, Allah. They, they are more depressed, they are more socially isolated, they are more dependent, etc., etc. And those believe in Almighty Allah, they have least depression and least anxiety and least social isolation. So I mean to say that they should be in one way or other way. The patient should be encouraged for the routine work. Number two, it should be encouraged for the salah for 5 times a day. Go to the mosque, slowly walk to the mosque and do the salah with the jamaat pray. It will be highly effective therapy because the social gatherings are there in the mosque. They ask you about anything, and the person who is ill will be very happy because the reassurance is given by the others. So this is my lecture on the chronic obstructive pulmonary disease. If anything asked, I have got the website and the WhatsApp group, and my WhatsApp group number is 0336 131186. If you are dialing outside, +92 336 131186. I will repeat it again, +92 336 131186. Now you want to add in that group that is called MIPME, MIPME, to ask, name yourself, who are you, and request that you should include the MIPME. All my presentation will be sent to you automatically in the MIPME group. This is a number which I have told you. You can be benefited by asking questions. Any question from any final year student is entertained on this ME group. So I will inshallah ta'ala take another lecture on the other subject of the pulmonology. Inshallah, we'll meet you soon. Allah Hafiz, wa ma alayna illa al balagh. Assalamu alaikum wa rahmatullahi wa barakatuh.